I'm just interested in the choice صراحة. هم؟
لقيت يعني new medication فقلنا نعرف أكتر عنه.
والله هو it's a great idea. هو I can tell you محدش يعرف كتير عنه outside of the people who actually used it in trials. We had another PROTAC. Um, Arvinities is the company. So Arvinities actually is doing PROTACs, for a while. So we had another PROTAC in a phase one, didn't mature to phase three. They're interesting. Definitely يعني worth the conversation.
Yeah, Dr. Jaylan also, I think she is here. So,
Hello.
Hello.
hi, Dr. Jaylan, how are you?
Good.
Okay.
Thank you
So,
so much, Dr. Kalibu, for joining.
Thanks for the invite. Do we have? I don't know the nature of this meeting. Do we have?
I'll share the screen. And we are going to have like a one-on-one discussion with Mariam. And so feel free to stop us at any point to add or correct on anything, okay?
Yeah.
The screen share. Can you see the screen?
Yes, we do.
Yeah,
Oh, great. How are you, Maria?
fine. How are you,
Okay.
Dr. Munder?
I'm very well. I just called her 10 minutes ago. Okay, so we are going to talk about this paper that's called the Vepdegestrant, a PROTAC estrogen receptor degrader in advanced breast cancer. It was published in New England Journal of Medicine just about 2 months ago. So can you tell us, Mariam, why do you think the two pharmaceutical companies, Pfizer and Arvina, united together to think about making this new drug?
Okay, first I would thank you to make me share in such fruitful discussion and conversation. I would thank all attenders and speakers, Dr. Ahmed, Dr. Mustafa, and Dr. Jailan. Uh, Today we will discuss phase 3 in human study of a novel endocrine agent or PROTAC, proteolysis targeting chimera antagonism. It's one of multiple new novel agents reported or approved in the estrogen receptor positive HER2 negative advanced breast cancer, either local regional metastatic breast cancer. As we all know, estrogen receptor positive HER2 negative breast cancer accounts for approximately 70% or more of all breast cancer cases, and this is very common. And as we all know, there are multiple patients, about 80% or more, progress or become metastatic on first line or subsequent line of endocrine therapy. So regarding our patient population, is a very large patient population. So this is an important topic to discuss. Novel agents include the SERDs like selective estrogen receptor degraders or SERC or SERONs, complete estrogen receptor antagonism. All novel agents all focus on the point of estrogen receptor resistant, which are acquired resistant in estrogen receptor genes, or most commonly ESR1 gene, which account for about 40 to 50% of patients. All patients with metastatic disease or a local regional advanced disease have been progressed on prior endocrine therapies and cyclin-dependent kinase 4 and 6 inhibitors. And still, till now, no consensus on the standard of care for patients who had progressed on these lines. As we all know, of novel agents, patients may receive PI3K inhibitors or novel agents like alpelisib, ACT1 inhibitors, PATEN inhibitors, and other targeted agents, and all these targeted agents still don't meet all needs for our patients. For example, PI3KCA inhibitor, PI3KCA gene mutation, some targeted agents like fulvestrant plus alpelisib is still not approved for this subtype of mutation. So we have a large population of estrogen receptor positive HER2 negative breast cancer still unmet for their treatment agents. So our trial today is a phase 3, as we have mentioned, trial in human trial assessing efficacy and safety of a novel agent compared with a CDK4/6 inhibitor therapy in this subset of population, which is estrogen receptor positive HER2 negative advanced breast cancer, as we mentioned now, not amenable to surgical resection nor radiotherapy.
Okay, so let me tell you about the mechanism of action of this drug. Yeah, so this is a cell, this is a nucleus, and this is a cytoplasm. Okay, usually estrogen receptors are present in the cytoplasm. That's where they catch estrogen, they bind to its receptor, and then enter the cell to the nucleus. Where they start transcription of proteins that are responsible for proliferation, invasion, cell survival, and angiogenesis, carcinogenesis, I mean. Okay, so this drug, this is our drug. It has 3 parts. The red one, it is the one that binds to estrogen receptor. Okay, the blue one, or this, I don't know if it is green or blue, it binds to an enzyme called E3 ligase. This is a member of the ubiquitin system. You know, this system is responsible for tagging the molecules in the cell that are going to be degraded by proteasomes. Okay, so when this vepdegestrant binds estrogen receptor with the ubiquitin member, it leads to its proteolysis by the proteasome. Okay, and then this molecule is recyclable and can be used again to cause more and more degradation of estrogen receptors. Okay, so this is different from other cells' mechanism of action, where they just bind to the receptors irreversibly, and with time, in the end, it will be degraded. This is supposed to be more powerful mechanism of degradation of estrogen receptors. Plus, it is recyclable. So, on the contrary, the cells are not. Each molecule binds to the receptor, and that's it. It's not used again. Okay, so let's hope that this fancy mechanism of action is translated to a better survival in our patient. Okay, can you tell us about the study design and methods?
Okay, regarding our study, it's phase 3 clinical study, interventional study, as we have 2 treatment arms, one of our novel agent vepdegestrant and the other of fulvestrant CDK4/6 inhibitor used in second-line setting. So it's phase
It's
3.
against fulvestrant, Mariam, it's against fulvestrant alone, you know? Fulvestrant single agent, not fulvestrant CDK. Patients received CDKAI in the first line, and when progression, they were randomized either to vepdegestrant or to fulvestrant single. Okay?
Okay.
Okay, continue.
So it's a phase 3 a clinical interventional study, multinational. It's an open label and also unblinded. Both treatment arms are well clarified. Our treatment population, as we have mentioned, estrogen receptor positive HER2 negative advanced breast cancer, assigned in our study or our trial 1:1 ratio to receive vepdegestrant and fulvestrant. Our study, our subset of population or our population study are randomized in a 1:1 using the international randomization technique. So our study have promising clinical data. So regarding the eligibility criteria for our study and randomization.
Just let me comment that this image shows the countries that participated in the trial. This in verbal has participated, and all these pale cities and countries has more fertility. So our population is not represented in this trial, and this can have a negative effect on the generalizability of the data. So you have to process this with caution, because here we don't know actually the prevalence of the ESR1 mutation in the Egyptian population, for instance. So, and it was not tested on our people too. So, you
Can I
just put that in
just
mind.
interject for 1 second
Yeah,
here? So
yeah.
I know that maybe we don't know a lot of information about the Egyptian population, but it is known from the other populations like the Western countries where research is being conducted that this is a mutation that evolves over time. Patients don't initially present with it, and then it develops when patients have been on aromatase inhibitors for a long time. So its prevalence is about 40 to 50%. I think it's across the board. So I think, and it would be maybe a nice project to launch if you have the capability to see if the same concept holds for the Egyptian population, because it's not a founder mutation, it's a secondary mutation that evolves over time. And this is the prevalence roughly after progression on CDK4/6.
Yes, yes. I agree. We need to do more on our people to know exactly. Maybe it's more than 50%, maybe it's a little less, maybe it's the same.
Yeah.
Okay, so it was open label. This means that both participant and researchers knew that what medication they were receiving. It's slightly higher for liability against if it was the blinded trial, double blind. So as Mariam said, what was the outcome, Mariam, of this trial? The primary outcome?
First, I will mention the stratification method, the stratification arms or factors in our study. Here we stratified our population into two subsets or two stratification arms: the presence or absence of ESR1 mutation and the presence or absence of visceral disease. We have a primary endpoint in our study, which is the progression-free survival, and secondary endpoints, which are the overall survival, overall response rate, clinical benefit rate, and others. Our study has been conducted from 3rd of March 2023 till the end of October 2024, and still ongoing trial. Still
So this
more
is
than
a
20
relative
patients.
short. Yeah, Mariam?
Yeah. I think it's
Yeah,
short duration for follow-up.
yeah. Okay. So you said that randomization used the interactive response technique. So this is like an AI that is responsible for randomization. It has some advantages, like it's rapid and time efficient. It is automated, so it's less human errors, and it maintain allocation concealments. Also, it can audit the trial and tell the researchers if there is like something wrong in the design or in the implication. But it has also some disadvantages, like it is expensive and a little bit time consuming, and it's in the initial setup, and it requires some infrastructure that has to be present in the site of the trial. Also, it's liable to errors or system failures, and sometimes you don't understand how it is conducting its calculations. And also, it may delay enrollment in emergency. So can you tell me, Mariam, about the eligibility criteria of this trial?
Our study has key eligibility criteria. Our inclusion criteria simply patients enrolled of either sex, women or men at age of 18 years or older. They have a confirmed diagnosis of ER positive, HER2 negative, local regional recurrent or metastatic breast cancer, not amenable to surgical resection nor radiation. Measurable disease must be present according to the RECIST version or RECIST criteria for solid tumors. Non-measurable only bone mets is available. ECOG performance states of 0 or 1. Regarding the progression as we have mentioned, we must have a progressed breast cancer on prior line. Regarding progression, this progression is evident radiologically, but the most recent endocrine therapy the patient has had must be more than 6 months prior to disease progression, and our radiological progression has occurred during or after the last line of therapy. Also, regarding the treatment the patient has progressed upon, a patient may have one line of CDK4/6 inhibitor therapy in combination with endocrine therapy, and only one line of CDK4/6 is a must in any setting, and less than or equal one endocrine therapy in addition to CDK4/6 with endocrine therapy. This is simply the inclusion criteria, but I have masked the contraception method, and this is a confusing part. Patients with either sex are permitted or allowed to receive contraceptive method during the study. Maybe due to the teratogenic effect of the drug is still unknown. I don't know exactly yet. Patients of the child, women of the childbearing potential are allowed to continue with the use of an LHRH agonist, and also men. Regarding the exclusion criteria, active brain metastases, inflammatory breast cancer, advanced symptomatic visceral spread at risk of life-threatening complications in the short term, as this will impact the progression-free survival, impaired cardiovascular function or clinically significant cardiovascular disease, and prior treatment with any novel agent like our treatment arms, Vepdegestrant, Fulvestrant, Elacestrant, mTOR, PI3K, or ACT pathway inhibitors, and PARP inhibitors, or any targeted agents. And lastly, chemotherapy for advanced metastatic disease. And I also think this is a pitfall in our study, the exclusion of use of chemotherapy in the advanced setting.
Usually in ER positive HER2 negative, chemotherapy is not used frequently. They give it just in later lines because they have more endocrine therapy and more targeted therapy to give frontline. Not like our daily management and our resources setting. It's important to just, like you said, that primary resistant disease patient were excluded, patient with active brain metastasis were excluded, like most phase 3 trials, and then we find it difficult to manage those patients. Patients with ECOG 2 or 3 were also excluded. We frequently see them in our clinical setting, and the patients with cardiovascular disease, because the Vepdegestrant has a cardiovascular side effects, long QT interval. Okay. So statistical analysis, this is like the most difficult part for me. Did you notice anything that is worth mentioning about the statistical analysis in this trial, Maria?
I think the worst thing in the statistical analysis is that all patients have received fulvestrant in any setting, and fulvestrant is one of the treatment arms. I do mean the stratification itself is confusing for me.
Stratification?
The comparison arms, fulvestrant versus
Yes.
vepdegestrant, and all patients had received fulvestrant in any setting.
No, they were excluded. Patients who received prior fulvestrant were excluded from the trial.
Okay.
But you can give it if he hasn't received it before. Okay.
Simply we have maybe in that we have two subset of populations, the ESR1 mutated positive subpopulation, and all the intention to treat population. The percentage of endocrine resistant cases will be more in the old population more than the ESR1 positive mutation.
Okay, so what I found interesting about this trial that they have, like we said, we have PFS, the primary endpoint, and we have the secondary endpoint, OS, and the objective response rate. So within each endpoint, they did what's called a gatekeeping procedure. This it aims at decreasing the risk of type 1 error in statistical analysis. So they decided to conduct the statistical analysis first on the ESR mutant population, and if it was positive, they would continue to do the testing on the whole population, the intention to treat. That means that those patients who were randomized in the trial. Okay, and if the BFS was positive too, they would transfer the 75% alpha will be reallocated to the overall survival endpoint. Okay, and then the overall survival endpoint will be tested with the full alpha. You know, alpha is the type 1 error. This is the risk of rejecting positive null hypothesis. اوكي النال هايبوثيسيس ده اللي هو ان احنا النال هايبوثيسيس ده بيقول ان مفيش فرق ما بين التو ارمز ماشي مفيش فرق ما بين الدوائر هما بقى احنا الهدف ان احنا نعمل ريجكشن للنال هايبوثيسيس ده ونقول ان في فرق ما بين التو دراجز ماشي فتايب 1 ايرور بقى ان انا اغلط واقول ان هو في فرق ما بين التو دراجز وهو اكشلي مفيش فرق ما بين التو دراجز It's complicated صح
And I think here, like from a drug company perspective, uh, the way they do this, and of course, like statistics is above my pay grade, is not my forte at all. But because we've discussed this before in similar trials, they try to get the best benefit of everything that they test. So they have a certain amount of error that they're allowed to work within, and then they do multiple spending. They spend some of it on the primary endpoint, and then they save some of it to spend on so like they spend some of it on the PFS, and then if that holds true, then they spend the rest of it or reallocate the rest of it to the overall survival, just in case they end up getting lucky, and just in case the drug ends up working for ESR1 mutated and ESR1 non-mutated patients, then they would get the approval for everything. So it's like a gambling approach.
Thank you for the clarification.
Yeah, I agree.
Okay.
Dr. Khaliwi said, I think, you know, this is the main difference. I mean, a lot of the other studies would have primary endpoint and secondary endpoints. So this is not uncommon, but the way that they did it is that they're trying to limit their losses. So instead of having distinct secondary endpoints, they're using, in a way, something along the lines of Bayesian statistics. And so if this ends up being positive, then we're going to proceed with this analysis. So because of this, the second analysis, which are not primary endpoints, they inherently are linked to the error rate in the primary analysis. It's kind of like saying, you know, if I reached my destination, then I'm going to take the next step. But you don't know if you're going to reach your destination. You have a little bit of a wiggle room there, right? And so therefore, you go into your next step depends on that wiggle room, and going on a third destination depends on the wiggle room still. So because they are doing it in a hierarchical fashion. The reason they're doing it in a hierarchical fashion because they don't have a lot of money. So because what's happening is that they're gonna shut it down if they're not seeing, you know, a signal after the second analysis. They don't have to do long-term follow-up to detect overall survival. It's gonna be a little bit tricky, and so that's why they're milking the way of their you know, of this endpoints essentially. Big pharma companies, they don't care, you know. We'll continue to follow up 5-10 years, but these guys don't want to do that. So that's why they're limiting some of their long-term endpoints.
Thank you for the clarification. Okay, Mariam, let's move to something we understand more. Can you tell us about the demographic characteristics of the population?
Okay, regarding the demographic characteristics, it was generally well balanced. but they not included the p-value between the two standardized arms. Plaque race, as you mentioned, is underrepresented in this trial. ECOG performance states of 2 or 3 were excluded, so this limited the generalizability. All patients received prior CDK4/6 inhibitors, equaling 96 to 98%, received them for advanced disease prior to our trial.
Yes, so they allowed CDK inhibitor used either in the adjuvant or in the advanced setting. But what happened actually that most patients had received it in this trial in the advanced setting. So I don't know if this may affect maybe limiting the indication for those who received prior CDK in the advanced setting alone, not in the adjuvant setting. I'm not sure. Okay, this is a PFS curve. Can you tell us about it, Mariam?
Okay, regarding the PFS curve, in our trial, tumors were assessed by radiology, either CT or MRI imaging, including chest, abdomen, and pelvis every 8 weeks for the first 48 weeks. Then every 12 weeks thereafter, and full body bone scans were also performed at screening, and then every 24 weeks. Also regarding the stratification, the ESR1 mutation testing was determined by circulating tumor DNA or by blood test initially. Our patients were followed up by this radiology over approximately 2 years period. So in the intention to treat population or the overall population, there was a progression-free survival of about 0.5 month, which is no difference. But in the ESR1 positive population, as we see, there is a separation of curve of about 3-month interval. In the ESR1 positive mutation subpopulation, about 165 events occurred in the study, positive events occurred in the study. And about 3-month progression-free survival was achieved from our study.
Yeah, so the difference was 3 months between the two arms, and p-value was significant, less than 0.001.
P-value
But in
was
the
less
whole,
than,
yes,
P-value was significant, less than
yeah,
0.001.
yeah, but in the intention to treat population, there was no difference. Fulvestrant reduced from 2 to 3.6 months, which is similar to the historical PFS of fulvestrant and the other trials that were conducted previously. To Dr. Khanini and Dr. Jalan, do you think yes, it is statistically significant. Do you think it is clinically significant?
Ahmed, do you want to start?
Sure. I mean, so I guess the major point here is how poorly is fulvestrant have proven to do um with the ESR1 mutations. I think that these patients essentially we historically depended on fulvestrant for these patients. But more and more data comparing fulvestrant and ESR1 mutant shows poorer and poorer outcome. So I think from a clinical standpoint, I would argue that the answer is a yes. I mean, obviously, we would hope more time being spent on these agents in a BFS. However, 5 months is better than 2. The other thing is that this is the median. Some people do better, some people do worse. Although I have to argue that, I have big qualms with the comparative arm in general for this trial. That's my 2 cents in general. That is it worth it? I think it does. Just when you look at the fulvestrant arm and how they're doing. But I'll leave the smart insight now to Dr. Al-Kalibi.
So, okay, so I have I don't know, I have so many things to say here. But in a nutshell, so the first thing is historically for these trials, why have we been comparing everything to fulvestrant, even though
Mhm.
it's been proven multiple times that the fulvestrant arm after progression of CDK4/6 inhibitors on all the trials, even the Emerald trial for elacestrant and some other trials that haven't even been proven to be positive, the PFS on fulvestrant is exactly about 1.8 to 2.2 months. The thing is, fulvestrant has been approved in maybe 2002 or like way back in the day, where we didn't even know anything about the ESR1 mutation. So it was an FDA-approved drug. So now the drug companies, they have a conflict of interest, and I think that they want their drug, like whatever drug that they come up with, to win. So then they compare it against the lame fulvestrant that we know doesn't work. So you'll see this theme across all these trials for all the new SERDs and SERCAs and PROTACs. So we all know that fulvestrant is not a good drug. We all know that it doesn't work for ESR1 mutation, but they're allowed to use it because it was an FDA-approved drug before the new SERDs came on. That's the first thing. Now, the second thing is, I think that these new drugs work for some patients with ESR1 mutation, but they don't work for about 40% of the patients, and you'll see this on the curves. See how the curve like takes a deep plunge before the curves start to separate?
Yeah.
So even though just like forget about the overall population because we didn't see a difference, but like so the hypothesis is that we can restore endocrine sensitivity if we give these drugs to patients with the exact mutation that we're looking for, and that actually holds true for about maybe 60% of the patients. Yet 40% of the patients, they progress at the very first scan. So this is basically progression on the very first scan. So my take home from this curve, and actually this is the exact same curve in the Emerald study with elacestrant and with all these new drugs, is that there's something missing. We don't have a marker for who's going to respond versus not, and the ESR1 mutation by itself is not 100% guarantee that these patients are going to respond. Those who do respond, actually, they do okay for a few extra months, but then we really have to do more work in trying to sort out these patients that are going to be endocrine resistant from the get-go. And this is why I would not use this drug for anyone who's crashing and burning, like with a ton of visceral disease and where I don't have like really the time to try something that may not work. So I'll use this drug and elacestrant and all these new drugs for a stable patient where I can, get it wrong for a couple months and then redirect the care to something different.
Okay. I think it's very beneficial that it's oral medication because fulvestrant injections are really painful. And if
Yeah.
the patient diabetic is going to develop abscesses and have so many problems because of it. Also, I think that using it as a single agent um, might not be like the strongest power. I think when it is combined with something that works on another pathway, like let's say CDK4/6 inhibitor or PI3K inhibitor, maybe it can produce better effect than being used as single agent.
Actually, this is a really excellent point, and I actually have a living example. I have a patient who progressed on a CDK4/6 inhibitor and endocrine therapy. I guess it was letrozole. And then when she progressed, we had at a different center a trial open. It was the Veritac 3. This one is, I guess, they called Veritac 2. So
Yeah, yeah.
I enrolled her in this Veritac 3, where they combined this PROTAC with another CDK4/6 inhibitor, like other than the one that, no, actually it was the same one. It was palbociclib. So she progressed on palbociclib plus letrozole, and then she got enrolled into the PROTAC, the Veritac 3. So then the only thing that changed was they switched the letrozole for this PROTAC, the Vepdeg, and she actually responded for 18 months. So I
18
guess
months in a second line setting, but she was in ether one.
she had 0.3% ESR1 mutation.
Oh, it's a little low VF, but she was positive. Okay.
Yeah,
How long
but
has
like
she been on the CDK? Do you recall?
9 months only.
First line?
Yes.
Mm.
So
That's
I guess like the reality of these drugs is that they're always going to be used in combination. They just like have to prove that they're going to work, and then like even the elacestrant, we have the Elevate trial that's going to combine it with everything under the sun. I guess it's going to be the same thing with this PROTAC, but I heard that the combination with the CDK4/6 is not going to proceed forward. I don't know why. I don't know if you know any
an
insights
elacestrant.
about what's going. No, I mean the Vepdeg drug.
Oh, no. I don't know. I actually was walking on IST with Arvinis, but they're taking concepts. I think they're not putting it as a priority. They just want to get an FDA approval before any second line CDK, maybe. I don't know.
Yeah.
The other issue which you raised, Dr. Kalubi, is what is the second line setting? And you, Dr. Manar said, yani, so if you think about it, what if in a day-to-day, we don't use fulvestrant single agent, right?
Yeah.
Very rarely are we able to depend on this now. Many of us would do like a post-monarch slash, maintain kind of regimen if the patient had a like soft progression. If there's like a legitimate, like new disease, I'm very concerned, it depends, if there's actionable mutations or not. And if there is not, and I'm having a bad disease, I mean, you correct me, Dr. Klee, but I jump to ADCs a lot more sooner now. If I'm having like a bad disease, that is, but for most of the soft progressions, so Bernstein, from Harvard, in the Live, he had a very good comment is that, why are they still comparing it to fulvestrant? Nobody used that anymore, and that's true.
Yeah.
They're
The
doing
answer is
that.
because they
They
can.
can
There's
get away
literally,
with it,
yeah.
right? They can get away with it.
Usually use a weak comparative arm so that they show that this drug is amazing and produce
Right.
significant difference.
Yeah, and it makes sense when that's actually what we typically use in the clinic, but when it's not used in the clinic, it creates all of these kind of questions. And that graph I shared was a commentary actually about the progression, median PFS after patients who received CDK and an AI in the first line setting with different trials. So, all of these single agents, right? So you see on Serena 2, you see on your Elaine 1 study, which is the lasofexifene, and then you see in the maintain and pace, which they have done a little bit of a better job. These are only, and then the post monarch Ember 3. So Ember 3 is interesting because it's the first study that flat out after the fact, right? So they started in with fulvestrant versus imlunestrant, but then they added that arm, imlunestrant plus abema, compared to imlunestrant, and they managed to squeeze that in there in San Antonio last year. And as you can tell, at least numerically, obviously this cross trial comparison, at least numerically, they have really done a great job. And we also see similar numbers in patients who had um, uh, in patients who had a CDK4/6 post, and with just fulvestrant alone, this is the second highest population. So like in the maintain and the post-monarch. So again, I think that this is just an argument that, as both of you mentioned, we will have to use combination in the second line setting. And
So in that Ember trial, that when they used the combination, they actually showed effect in the ESR1 mutant and the non-mutant population. So that
for the
begs the
combination,
question.
right?
So I
Yes,
mean,
correct.
if we use another CDK4/6, like recycle another CDK4/6, are we going to overcome the fact that it only works for the ESR1 mutant population? I don't know the answer.
Yeah. Yeah, no, you're absolutely correct. I don't think we need to, right? I think if we have data, because technically, if you think about it, why did that ESR1 mutation situation even emerged, right? I mean, fulvestrant has been used for all patients. We really didn't pay a whole attention to the ESR1 mutant. It was elacestrant that showed preferential higher activity in ESR1, and it just seemed that a lot of these agents work now better on ESR1 mutation. Take that PROTAC, for example. Why is it only working in the ESR1 population? There is absolutely no physiologic reason. I talked with the MSL 2 times about that. I mean, it's a PROTAC. It's gonna lyse, the estrogen receptor no matter what. Is it preferential lysing to the mutant receptor? No, actually it's not because it's mutant independent lysis, right?
So maybe the reason why these patients without the mutation progress in the first place is another mechanism that's not even dependent on the endocrine pathway.
Mhm.
So maybe the PROTAC is doing the same thing, but the cancer is growing because of some other bypass pathway.
Right. And this is very possible. Um, so it's and then the other thing is how they excluded all the big 3CAs, any other mutation. They wanted clear population. So they really wanted endocrine, in a way, sensitive population, actually, in which they have little to not that much ESR1 mutation. Even in the most endocrine therapy line has to be 6 months or more. Um, but then you look at the Innova trial and you see how fulvestrant, with the Balbo and the inavolisib actually did a great job with overall survival for these patients. The fulvestrant, the big 3CAs historically, and the Balbo didn't have overall survival. If you put them all together, they end up having overall survival for big 3CA. And I don't think there's any other big 3CA agent, correct me if I'm wrong, like the Solar study or the for alpelisib or
ID?
capivasertib. I don't think the alpelisib or capivasertib. I don't think they had overall survival. But I have to check. But I haven't heard about any overall survival in big 3CA agents except with the inavolisib. Yeah.
Yeah, I don't know about the other two, but also like the in the ANOVA trial, they used it first line for the very resistant population that progressed quickly. So by hammering on all the three or the two pathways, I guess they did a good job.
Yeah.
Now, okay, let me ask another question. Like, so one to our colleagues from Egypt, do you have means to check the ESR1 mutation for patients?
Yes. Isn't it detected by NGS?
Yeah, or liquid biopsy. I mean, if you have a tissue biopsy, you can do NGS, and if you don't, you can do the blood. So, do you check for it, or clinically, or it's not available?
Not yet. Okay.
Okay. So so probably because you don't check it clinically, the one thing that I run into here is that I check it for patients, and the level of positivity is anything that's basically even 0.1%. And I always find for my patients they either have 0.5, 0.3, 1% max. And it looks like from the other trials, let's say the Emerald trial, which was reported maybe a couple of years ago, they said that the high allele frequency for this ESR1 is about 1.2%. So if you get a 2%, this is high. This is the definition of high. So you're not looking at 20%, 30%. And they said that the drug worked for any allele frequency, and it wasn't like it worked better for, like, if you had a 2% or 3%. It worked good for anyone who had the mutation in clinical practice. And I don't know if Ahmed now has been using this drug maybe for a couple of years. I've been very underwhelmed with the results. It only worked for one of my patients. Like, I used it 4 times. And now we're talking about the elacestrant, which is, similar concept to the PROTAC, but it only worked for one of my patients. That's it.
Exactly same experience. To the letter. I don't like this drug. I don't like single agent elacestrant. I started using it very frequently, but then slowly I've been using it less and less. We have Elaine 3, so with the lisofexifene, so and Abema. That helps a little bit in this setting if I have any SIR1, so I've been just putting them on that trial.
Nice.
Okay, Maria? Maria?
Okay, okay, I'm here.
Okay. What about the safety? that is reported in the trial?
Regarding it's an oral drug, it's quite safe, but among patients who received at least one dose of treatment, adverse events occurred in about 86.9% of all the participant patients receiving Vepdegestrant, equaling 312 patients. Of them, about 86.9 developed adverse events, but all of them are grade 1 to 2 adverse events. In the comparison arm, or in the other arm of fulvestrant, only 81.4% developed adverse events. The majority of patients in our vepdegestrant arm had grade 1 or 2 adverse events only. The most common adverse events of any grade were reported were fatigue. Fatigue was the most eminent adverse events of about 26.6% of patients who received. Also increased aspartate and alanine amounts, amine transferase levels. Nausea occurred in about 13.5% of patients, and the same adverse events occurred in the fulvestrant group, but with less percentage, about 10.7% on the increase in the aspartate level, and 10% increase in the alanine transferase level. Grade 3 adverse events occurred only in 19.2% of patients with the vepdegestrant arm, and only 14% in the comparison arm, the fulvestrant. Grade 4 adverse events occurred in about only 1.6% of patients in the vepdegestrant arm. The most common, as we mentioned, the most common adverse event was fatigue in the vepdegestrant arm in 18.6% of patients, and only 6 or less percent in the fulvestrant arm. Serious adverse events were similar in both groups, about 10% of patients in the vepdegestrant group, and also about 9% in the fulvestrant group developed serious adverse events. Only 2 patients in fulvestrant group have treatment cessation for adverse events, and 8% in the vepdegestrant group have discontinued treatment for the disease adverse events. Regarding the QT interval prolongation, this is a specific point. QT interval prolongation was reported in the vepdegestrant group, but in our study or in our trial, they have a subset of population who have a corrected QT interval fraction or measurement. Unfortunately, it has no significant value. So it's a safe drug, but of note, we will take care if patients will receive with concomitant drugs who have other QT interval prolonging effects.
Exactly. So if you plan to give it like, if you have approval of its combination with ribociclib, for instance, both can cause long QT, so you have to carefully monitoring. And if the patient has a high risk, you may not do this combination at all. Okay.
Okay.
So this is an ongoing trial for vepdegestrant in combination with valvociclib, in combination with the other CDKs, and in combination with big 3 inhibitors. So I think it may have a chance, like we said before, it's used in combination. Okay, so to the panelists, how do you think this trial can impact the current practice? And is there any recommendation for change in the future research?
Yeah, I guess we touched on these points during the discussion. I think that there's room to use any of these new medications for patients with ESR1 mutation. There's not a direct comparison between the SERDs and the PROTACs, and then there's going to be some other classes too, the CERCAs and some other newer agents, and I think they're going to replicate all these studies, and then the problem is going to be which one do we use after the other, or if a patient progresses on one, then that precludes us from using the rest of them because it's exactly like milking the very same idea, the very same pathway. I think of it as, using sacituzumab and trastuzumab deruxtecan. Like if you use one, then you most likely will get less luck with the other drug if you use it next line. So I feel like all of these drugs fall in the same category. I think they're going to prove to us that they're going to be used interchangeably. If you use one, I don't think you'll be able to use the other ones. And like I mentioned, there's got to be an additional marker uh, of endocrine sensitivity so that we don't subject the patients who are going to be very resistant from the get-go. And just to touch on this point one more time, because the VERITAC trial is a new trial, and I'm sure that they're going to have like 5 million other updates on it in the future conferences. There has been one update on the EMERALD trial, and then they found out that the patients who had a 18 months, like 12 to 18 months of progression-free survival on the first line CDK4/6 inhibitor and AI are the ones who are still maybe retaining some endocrine sensitivity and are more likely to respond to elacestrant. And I think this is going to prove that very same concept is going to hold for the trial that we're looking at. But we don't have any sub-analysis. We just like have the one that we just discussed. And in that trial, they allowed patients who did not progress for 6 months on CDK4/6 inhibitors. Like they're trying to really enrich for a population that is endocrine sensitive and not for the rapid progressors that may less likely be endocrine sensitive.
Yeah, I think Dr. Khalili summarizes, and we did touch about a lot of these points when we were discussing. My concern is that all of these will get FDA approved like next year, like together. Like imlunestrant and camizestrant and vepdegestrant, and then we'll go like, and then what? Imlunestrant will have a very reasonable chance of being the agent of choice if it got approved with the abemaciclib. I think that's really what, especially for wild type, that will basically be the go-to. I know they're filing for the FDA for the NDA, but I'm not sure if, what will be granted to them or not. Hopefully they have some data coming up in, I think, ESMO in a few months. So that would be interesting to see confirmatory data from that program. But at this point, none of that changes our practice. That's all interesting, but we are getting good-ish in a way. Results with CDK4/6 post progression and fulvestrant or switch to the endocrine agent. Even ESR1 mutation, and I usually use elacestrant very cautiously in patients with ESR1 mutation if I were to use it in a standard of care.
I guess the
Thank
key
you.
is the combinations, and we just like have to enroll patients in the combination trials.
Yeah, you have to have you're absolutely right.
Because in a
That's,
few years, I'm sure that like none of these drugs will be approved as single agent. Like they'll all be approved in combination depending on the other mutations or non-mutations that you're dealing with.
you know what I'm thinking? At some point, I feel like AstraZeneca will put TDXD versus endocrine therapy first line. They've been pushing it first line in every line because
Yeah.
now, technically you can do it as soon as the second line. I mean, it's as crazy. And
Destiny 20.
at the very beginning of the cancer treatment.
Yeah.
So, but I think that a lot of exciting information and data for the patients, and the novelty of this trial is really just the novelty of that class of medicine, which it's new, and if you think about it, it does not really have to end at all with the ER receptor itself. And so our evidence is doing a lot of PROTACs across many other cancers too. Exciting.
So I just like have a practical question. So for our friends in Egypt, let's say like somebody has the means to pay for anything. Is there a way to conduct any of this testing? Like, do you send the specimen somewhere to get like NGS testing or any of that stuff?
Yeah, sure. Yeah, if you can afford, you can send it abroad. Yeah.
So which company do you work with for molecular
I
testing?
haven't. all my patients are kind of poor,
Yeah.
but there are access. If I ask someone, he can tell me it's possible. Yes,
And Elacestrant, like, is it available, let's say, for no,
in
we're
the
not
system.
yeah.
No, no, but they can, get it from someone, a friend or a relative. You know, can happen if you have money. Anything can happen.
Yeah. I mean, that was my experience because like I did hematology in Egypt. So I used 3+7 my entire life. And
I know what it feels like.
yeah. So I know, but because like it's always like exciting to learn about stuff, but you sometimes are like so itching to use the stuff, apply it, and give the patients some
Yeah,
benefit.
In
yeah,
But
reality, though, I feel like, a lot of these agents, even with all the newer agents, don't really necessarily uh, make a huge difference in to be honest with you, very little drugs in the past 3 or 4 years actually impactfully, led to drastic change in the way we prescribe or treat patients. I mean, I can think of very few. Inheritor for sure. Possibly introduction of immunotherapy triple negative, but even that is fairly questionable. Um, I don't know. And really none of these surges or have been as exciting as we thought initially that they would be.
mhm. So you're not missing out on a lot of stuff. But excellent job doing this. I loved it.
Yeah, thank you, Dr. Mariam. You did all the heavy lifting, and Dr. Manar mentorship, with a great team.
thank you.
Thank you, Dr.
Okay.
Okay. Thank you, everyone. We'll meet inshallah next time in tumor board.
Thank you so much
Okay.
for the invitation.
Yeah, sure.
See you.
Thank you for
See you
attending.
Thank you,
next
Dr.
Thank you,
Khalid, for
everyone.
joining, and Mustafa for stepping.
week.
Bye.
Have a nice rest of the day.
Thank you.